All right, out with the Greeks, in with the Romans. In our last video, we encountered a few of the important complications of cirrhosis and what to do about them. One of those complications was ascites. And you can bet your Bacchus that there are numerous other causes of ascites besides cirrhosis. No portal hypertension necessary. In this video, we'll cover the presentation and diagnosis of ascites, while the bulk of the sketch will be dedicated to deciphering the acidic fluid analysis. Well, you know what they say. When in Rome, do as the Romans do. Get naked. What better place to discuss all the moist details of ascites than in an uncomfortably dampened, likely unhygienic Roman bathhouse? Ascites is the pathologic accumulation of fluid in the peritoneal cavity. By far the most common cause of ascites is portal hypertension due to cirrhosis. However, there are a multitude of other causes. It's important that you always determine the underlying etiology, as this has important implications for its management. The diagnosis of ascites is established with a combination of physical examination and abdominal imaging. See how this bath apprentice is smacking the side of this water-filled vase? Patients with ascites, regardless of the etiology, will typically have dullness to percussion in the flank. You're just knocking on a bunch of fluid there, friend. You may also notice a shifting dullness, which just means that the area of dullness changes location when the patient is on his or her side, which we tried to convey with those arrows, as well as the fact that he's turning that vase. It's pretty standard to check for a fluid wave as well. A fluid wave test is performed by having the patient, or an assistant, push down on the middle of the abdomen, while the examiner taps one flank and feels for the transmitted vibration in the other flank. The test is positive if you feel the tap. Patients suspected of having ascites based on history and physical examination should undergo abdominal ultrasound to confirm its presence. And man, are those some ultrasounds coming from that hollows. I could listen to that all day. But we've got some ascites to inspect. Once the diagnosis is made, the next step is to look for the cause of ascites. A paracentesis should be performed for newly diagnosed ascites, or for patients with pre-existing ascites who are hospitalized, or, thirdly, for patients with ascites whose condition is worsening. The initial acidic fluid studies should include cell count and differential, total protein, and SAG. If infection is suspected, the fluid should also be cultured. Let's get a saggin'. SAG stands for serum to ascites albumin gradient. On the left of the pillar is serum albumin, represented by this bath patron looking at an album in a sanguineous red robe. Lord Varus, over on the right here, represents ascites albumin. Looks pretty acidic to me. The minus sign on the pillar should remind you of the SAG equation. Serum albumin minus ascites albumin. And the double-masted ship symbolizes what number we're looking for, 1.1. Portal hypertensive causes of ascites, such as cirrhosis, typically have a SAG greater or equal to 1.1. This is why, on the right, we've drawn in our recurring porthole symbol. That must be quite a view from down there. In the presence of portal hypertension, hydrostatic pressure drives fluid, but not as much protein, from the portal system into the peritoneal space. This leaves behind a relatively high serum albumin concentration compared to a relatively low concentration in the peritoneal fluid, and, therefore, an increased gradient. Now that we can differentiate portal hypertensive causes of ascites from non-portal hypertensive causes, let's talk about the differential. We'll start with ascites associated with portal hypertension, the SAG greater than 1.1 side of the bathhouse. The total acidic protein concentration can be used to differentiate the causes of portal hypertensive ascites. And it's symbolized here by this protein-filled vase. Man, you know how many times I've been in a hot tub and immediately started craving a mostly raw lamb shake? I was born in the wrong millennium. Notice, too, that the shape of the handles forms a 2.5. Anything below the vase will have a total acidic protein less than 2.5, and anything above the vase will have a total acidic protein greater than 2.5. This big stony liver rock bench represents ascites due to cirrhosis, which typically has a SAG greater than 1.1 and a total protein less than 2.5. Cirrhosis is by far the most common cause of ascites in the United States. It results in portal hypertension and splanchnic vasodilation, which promote the transudation of fluid into the peritoneal cavity. Hypoalbuminemia and, consequently, a low plasma oncotic pressure also contribute to this process. Up in the bath, we've got ascites from cardiac etiologies. The floppy heart balloon represents chronic heart failure, while the heart tied to the ceiling depicts constrictive pericarditis. Because it's tied up and constricted. Ascites occurs in chronic heart failure due to activation of the renin-angiotensin-aldosterone system, leading to volume expansion and increased central venous pressure. Ascites occurs in constrictive pericarditis and other causes of right heart failure, including tricuspid regurg, cor pulmonale, cardiomyopathy, and progressive left heart failure, due to diastolic dysfunction of the right heart causing an obstruction to venous return and increased central venous pressure. The acidic fluid total protein is higher in these cardiac causes of ascites for two reasons. The liver, for the most part, is synthesizing all its serum proteins as usual. A higher serum total protein is correlated with a higher acidic fluid total protein. And secondly, the buildup of venous pressure is occurring beyond the liver this time. Venous back pressure on the liver causes lymph and proteins to leak out of the liver into the peritoneal cavity. These etiologies, therefore, typically present with a SAG greater than 1.1 and a high total protein, over 2.5 grams per deciliter. Next, Budd-Chiari syndrome, which is caused by obstruction to venous outflow from the liver. This can occur due to a primary venous process, such as thrombosis or phlebitis, or a secondary process, such as malignant infiltration of the hepatic vein. Either way, we're cutting off venous outflow, which we convey by putting a cork on the liver. In the acute version of this syndrome, this causes portal hypertension and ascites with a SAG greater than 1.1. We've made Bud here kinda in and out of the bath because total protein can be variable. This is because the liver function and total serum protein is variable in Budd-Chiari syndrome depending on if it's presenting more acutely or chronically. All right, now that we've set up the scene, let's flesh out this DDX a bit. And just when you thought it was fleshy enough. In patients with ascites due to cirrhosis, expect to see other signs and symptoms of cirrhosis. Jaundice is a sign of the reduced synthesis capacity of the liver. Asterixis and altered mental status are signs of hepatic encephalopathy, represented, as usual, by those flappy asterixis wings of Pegasus. And finally, palmar erythema, spider angiomas, gynecomastia, and impotence are signs of hyperestrogenism that's characteristic of cirrhosis. For a more complete picture of the clinical presentation of cirrhosis, head on over to our cirrhosis sketch at the Gorgon Cave. A paracentesis will typically reveal acidic fluid that's translucent and yellow. A common complication of ascites in patients with cirrhosis is spontaneous bacterial peritonitis, or SBP, which occurs due to the infiltration of gut bacteria into the acidic fluid. It's symbolized by this bath patron here, who seems to have spent a little too much time in the hot tub. Notice the bacterial garb he has on. These patients present with fever, altered mental status, and diffuse abdominal pain. And he's definitely experiencing all three right now. In a patient with ascites and cirrhosis, this is not a good sign. Time to get a paracentesis. In the setting of SBP, the acidic fluid may be turbid or cloudy rather than the usual translucent yellow appearance. A cell count with differential is performed to evaluate for infection. In fact, cell count should be ordered on every acidic fluid specimen, even if you're just performing a therapeutic paracentesis and draining that tense abdomen, for example. The diagnostic criteria for SBP includes a positive ascites fluid culture and neutrophil count of greater than 250 per milliliter. At Sketchy, our recurring symbol for neutrophils are neutro first responders, since neutrophils are like the EMTs of the immune system. Notice, too, that the oil canister thingy, is that ancient Roman medicine or something? Whatever. It forms the shape of the number 250. For more information on SBP, check out our cirrhosis complications and management video. Next up, heart failure. Assess for the typical clinical manifestations. Remember, ascites in this case